always takes a little bit. Okay, we are now recording.
Great. All right, everyone. So this is our second meeting of our Rulemaking Advisory Committee for House Bill 2517. It's possible this will be our last meeting if we can get close enough to a consensus here, but we'll see how the discussion goes. Since we are all on Teams, we can see people's names, so I think we can mostly dispense with introductions, but there is one person on the phone. Could you let me know who you are?
Oh, that's Ethan Baldwin, DFR.
Hi, Ethan. Great.
Hello.
I think there might be one or two people who weren't here for the last meeting, so if you could introduce yourselves to the group, please.
Hi, this is Sabrina Riggs. I represent the orthopedic surgeons, ophthalmologists, anesthesiologists, and the Dental Association.
Thanks, Sabrina. And Dr. Holliday, I think you were speaking, but on mute. Still on mute, I'm afraid. Well, we'll see about the mute there. But I guess we can get started. Is there anybody else who would like to introduce yourself?
Yeah, this is Linda Gardner from Pharma.
Hi, Linda.
Hi, this is Bill Bushka with Samaritan Health Plans.
This is Antoinette Iwachi with Columbia Health Solutions.
Hi, Antoinette.
Meredith Shields, Cigna.
All right, thanks everyone. Okay, so I sent out the comments that we received, and we only got a couple, and they mostly related to the reporting requirements and the rules there. So one was from Providence and one was from the acupuncturists, I believe. So would either of you like to speak to your comments? We can start with Providence.
Sure, thanks, Jesse. This is Sarah Petty with Providence Health Plan. Just the feedback we got from our teams about reporting for ease of reporting and the reporting deadline to just keep it more broad and accommodate the current platform that we use.
So one question I had about that was, would that require a change in the language that we proposed? Or, because I had kind of been thinking that the way we had worded it would be relatively high level in that way.
I agree with you. I was gathering perhaps additional language if necessary to see how we currently report it, and don't need to add language, but just for example, there's those other kind of buckets that we use.
Right, okay, thank you. And then is someone here to speak for the acupuncturist's comment?
Hi, this is Lisa Poole. I represent the Oregon Acupuncture Association. And our concern was that the reporting have some way to also include partial approvals or partial denials, depending on how you look at it, because that is definitely a serious problem that we have over in the physical medicine realm of the world. I realize that if we're talking about other types of prior authorizations, like for an MRI, this wouldn't really be applicable. So I realize it's a little bit more specific to treatments in which there's going to be recurrent treatments going on, like with physical therapy, acupuncturists, and chiropractors, massage therapy if it's covered. And so sometimes we will request, based on medical necessity, 12, but we might only get 1 or 2 approved. And so that's a serious problem that we continue to have. And so we just didn't know if there was a way to figure out how to track those, approvals as partial versus a full approval. Could we count, we can talk about logistics and how to make that happen, but how could that be tracked a little bit better, since that is a problem in physical medicine.
Yeah, so that's a good question, and I'd like to get carrier feedback on it. One thing I would say is that we generally treat a partial denial of a prior authorization as effectively something that is akin to a denial that could be appealed, for instance. That's part of our regulatory framework for prior authorization. So, if a request is made for 12 visits and only 6 are approved, that constitutes an adverse benefit determination that could be appealed. But there isn't anything in the bill here that says anything specific about how to handle this. So I was wondering, what the carriers would have to say about what they currently track in this area, or what we could realistically ask for here. What would be helpful? Anybody have any thoughts?
Hey, Jesse, this is Gary, Pacific Source. I think it may go back a little bit to what's the question being answered with the data we're gathering, and what type of analysis, if you want to look at it as a negative or positive, those partial denials. I'm almost tempted to put out there that we identify as its own category. So you have paid, denied, and partial. And then for big B, and then for big C, you would follow in suit, you put them in 3 areas. So C is approve, and let's see, and then D, I mean, you could break it out 3 ways. What I'm afraid of is somebody gets in there and says, what's a partial? You're really getting in the weeds. So I'm not sure how far in the weeds you want to get with this data. And if it's beneficial, I don't know how many partials there are in compared to, what portion of the request we receive. So I can't say there. Other carriers may, but at Pacific, I don't have that right now.
And Jesse, this is Antoinette from Cambia. I'm sorry, I'm on my cell phone. I cannot see the document. But that's one area I know our prior authorization folks are struggling with in terms of what is a partial denial. And for what they've been describing to me, they said they could receive a request, and within that request could have about 10 services, some based on medical necessity, others based on other stuff. And if they deny 1 or 2 within that one request, is that what the division is considering a partial denial? So one recommendation was that rather than say request, maybe it would be services that may help solve the problem. So those were the preliminary feedback I received from my prior auth folks, but we will be providing some written comments on feedback on that after this meeting.
Yeah, that's a good point. And also, the way the language is structured is sort of about the way the language in the bill is structured, which we've just replicated in the draft rules, is really about the request rather than the specific services or the number of services, which would be an issue with partial denials. And I don't know, it might be going a little too deep into the weeds and collecting too much information to get the level of detail of the reasons for the denials on the partial denials, because then it just becomes potentially a large amount of information. I don't know. I'm not sure what the best way to handle this is. One approach would be to say, if we want to know just a raw number of how many partial denials there were, that could be its own separate category, which we could add by rule. But I'm not sure whether that would be valuable or not.
Well, the reason why we brought this up, in all honesty, is that we see from the acupuncturist physical medicine standpoint, we see that if a partial approval has happened, that has both a negative and a positive, as Gary was pointing out, that what we don't want to do is have the insurance companies being, docked for a full denial when that's not what happened. Yet we also don't necessarily want insurers to get credit for an approval when a full approval didn't happen. So we were thinking this third category would be kind of helpful just to kind of understand how many are kind of fitting into this middle category. And I think that could be helpful for both the providers as well as, it's a win-win, I think, for the insurance companies as well as for us to kind of figure out how much of that is going on. And then it might be that down the road we need to dive into that deeper. But I think in this initial round here is having that third category. I see that as a positive for both provider and insurance.
Yeah, and from our perspective, I think there could be a danger here that different companies would approach this differently. So some companies might count a partial denial as an approval for the purposes of this report, and some might count it as a disapproval for the purposes of the report if we don't make a third category. But I also don't know how insurers' systems work in terms of keeping track of this level of detail about prior auth requests and what would be workable there. I recognize, especially for the first year, we might not quite be there in terms of what we could get, as we talked about at the last meeting. But I'm wondering what's workable here and what would be most helpful for all parties.
Is it helpful for the insurance side of things for each unit to be counted as an approval versus denial? Is that more cumbersome or less cumbersome in terms of the reporting from the insurance perspective? Like, for example, if I'm requesting 12 units of acupuncture, I get approved for 6. Could there be 6 approvals and 6 denials, or is that just making it too muddy?
I think you're getting muddy there, Lisa. And that's why I was trying to ask Jesse what level of analysis or review does he want to do with this? Because, my people have told me, yeah, we can get to the unit level, but I don't know if it's necessarily captured in the system all the time. And then what benefit is it due? I like the third option is just an overarching, any partials, approvals can be considered, a denial, but you make a separate line item, like an E in your rules, just to denote that, hey, you're focused on the high level, paid, denied, but just to let you know, some of these denials were partials and here's how many they were. And then you can keep going through your work at the higher level.
Yeah, I mean, my potential concern about getting down to the unit level would be that maybe we would get situations where we weren't really looking at things apples to apples. If different carriers dealt with requests and counting up the units in different ways, and then maybe we'd have to get into the weeds about how to define that so that all the carriers were doing it the same way, and it would just be a very in the weeds level of detail for what I think is meant to be a relatively high level report in terms of getting the overall numbers.
Well, I really like Gary's idea, and I think that it really does, I think, offer just a little bit extra detail without necessarily getting too crazy with it as well. And perhaps this is a much smaller, issue than what could be true, but I think this will kind of help identify that, because if there's quite a few of them that are partial, then that might down the road result in just another conversation to figure out how we might be able to navigate that.
Dave, go ahead.
Hi, Jesse. Can you hear me okay? So, yeah, so I think with this, what's going to become important is, the definition. What do you mean by the partial denial, so that we can make sure that we're providing, the piece of data that you're looking for. And then, as was kind of mentioned before, that transition period, from this year's data that we're reporting next year into the 21 reporting period that we report in 2022. I'm definitely going to be asking for some flexibility there, because I don't know to what extent, we're capturing this in a reportable way currently, because as you described it, right? I mean, recognizing that really anything that's not entirely approved as an adverse benefit determination is one thing, right? We handle that on appeal and deal with that. But at this kind of level of, okay, do you track that prior authorization in your system as a partial? I don't know for us if it's something we've got at that detail. So again, I mean, of course, moving forward, we can reconfigure our system to report the way that we need to for this, but doing that retrospectively is just gets really difficult because of the size of the data and the fact that you don't have it, readily reportable. So just wanted to kind of emphasize those 2 points.
Makes sense to me. All right. Well, we can try drafting something that would create an additional line item here and get feedback on that. Whether that necessitates an additional meeting is another question, but we can wait until we get to the end here before we decide that. Might be able to get feedback just in writing. We'll see. Anybody have any further thoughts about that at this point?
Hey, Jesse, this is Gary Pacific. I would just say, when you write that, make it at a high level where it's, if there's any part of the treatment that was denied, just call it a partial, because we're looking at a high level. If you get too wordy, then I think you might generate more questions.
Yeah, that was what I was thinking as well.
Cool.
All right. Not hearing any further comment at this point. The other thing that was on the agenda to talk about is we got a question from Gary at Pacific Source, not specifically about the rules, but about the interpretation of the bill. And I thought that this would be the best group to discuss that with, whether we decide to do anything by rule or not, just to make sure that folks are on the same page about the issue. And I could try to channel Gary's thoughts, but since you're here, maybe you could just ask the question yourself.
Sure, Jesse, no problem. I had some internal comments come back to me in regards to the bill where it amends OS 743B.423, and specifically gets down to subsection 2, little f, and the language in the bill was modified. I reached out to Rick Blackwell, who's our government relations, try to understand what the intent was when they made these changes to the language. And he wasn't real sure either, so we want to at least bring it up and make sure that we understood it correctly. What the language says is, right now, it was amended to read, the insurer must use a physician license under ORS 677 to make all final recommendations regarding coverage of a treatment, drug, device, or diagnostic or laboratory test that is subject to utilization review and to consult as needed. Where before it was just the licensed physician shall be responsible for. And the question that came up is, with the new language, is it to be read that a licensed physician has to review every single recommendation regarding the coverage and treatment? Because that's very burdensome on a company. Right now, we have a licensed physician who oversees the changes, but they don't review every single one. And so that's the clarification we were looking for.
Yeah, I think it, from our perspective, it would be helpful to get some feedback about how everyone was interpreting this language, because it's a little unclear what making the recommendation versus being responsible for the recommendation is supposed to mean in practice. You could kind of see it a few different ways. Dr. Holliday, please go ahead.
Yeah, hi, David Holliday here. I'm a child, adolescent, and adult psychiatrist in private practice, and here representing OPPA. Sorry I couldn't attend the first one. I did have a chance to look at all you handsome people on YouTube, and it was great to have that level of information. And as a practical matter, it'd be nice to know there's a doctor looking at this. I'll just use one quick example. Just this week, a patient of mine with severe ADHD wakes up in the morning, he's a hellion. Once his medicine kicks in the morning, he's fine. About an hour later, there's a new medicine called Jornay. I try not to prescribe, fancy new medicines because they're so dang expensive for everybody and drives up the cost of medicine. But that medicine, you take it at night and it kicks in the morning, and he needs it. He's been on one medicine. I can shift him to a different first tier medicine, but it's going to be the same thing. It's not going to work for another hour. And I just am not confident that a non-physician is going to have the, in spite of looking at my record where I document the necessity for it, is going to have the information, the medical knowledge to make a good decision about that denial.
I mean, it seems clear to me that the intent was to increase physician oversight of the process, but I guess it would be helpful for me to have a better sense of what that means in practical terms. Courtney, please.
Hi, everyone. Sorry I was late. Courtney Dresser for the Oregon Medical Association. And as many of you know, this was our lead bill for several years. My understanding is that this was not a piece that we had asked necessarily for. So I think there was a combination of legislative counsel and also some cleanup and maybe a little bit of language from DCBS there. I can't quite remember. But I don't believe it is having them review every claim. It's having them review recommendations to coverage changes. So I don't think is looking at every prior auth. That obviously that would be too much. But it is looking at as insurers make recommendations to changes in utilization management, that there be kind of somebody kind of signs off on that. So hopefully that's, again, I think what Jesse just said, is process more than the actual or the kind of the framework of it, and not so much the day-to-day operational, each prior auth has to be reviewed by a physician. That's not what we're looking for there. Hopefully it's helpful.
Yeah, and I appreciate that, Corey. So it's more of an insight change in the okay.
Yeah. So and so this is where we got into, you have to provide written notice of these changes, all that. But before, I think what is done now is physicians have to kind of see that a physician license under has to work with your team to kind of say, yep, that makes sense. I think that's what we're asking for. So I don't think we're necessarily asking for too much change in the process.
Okay, that helps us. Like, so someone read it literally for all recommendations, which is basically all.
No.
Okay.
No. That would be too much, I think. So no, I think you still do your same prior auth process. If there is a denial in the claim, and a lot of MDs are, and you have a lot of chief medical officers that are involved in those prior auth review too. And then if we're talking about an individual claim going through an appeals process, that's when you would use a same and similar specialty. So like for Dr. Holiday, if he had an appeal process, then you would look to have a psychiatrist, specifically a child psychiatrist, if you can, do that review. That's an individual claim that's been appealed. So that's only when that happens. So this is really more foundational, operational on that piece.
That all makes sense. That's the most practical.
Okay, thank you.
Yeah, and looking at it, the technical language changes there, I think, are from LC, that they have been kind of going through and updating statutes using their definition of utilization review and trying to make things a little more specific, even when not specifically requested to do so by the people requesting the bill. Yeah, that all makes sense to me. I am not hearing that this is something that we necessarily need to provide guidance on. Does anybody think we should?
No, but I really appreciate, Gary, that you asked the question, because we were also really confused by that as well.
Great. Seems like we're making fairly rapid progress here. I actually didn't have anything else on the agenda here because the comments we received were fairly limited in scope, which I'm hoping is a good sign. But I can open it up here and see if anyone on the call today has any additional feedback they want to provide on the draft rules or the draft statement of need and fiscal impact or anything else. Jennifer.
Hey, Jesse, I just wanted to make sure that the reporting that we're doing is going into the patient protection reports. Is that correct? I just want to, it seems fairly obvious, but I just wanted to double check because that's what I've been telling my people, so.
Yeah, that is correct. And our team that works on those reports is going to be mocking up a new version of the form that includes the pieces here, and we'll try to share it for comment in advance as well. It doesn't have to be part of the rule, so it could be a little bit of a longer process to get that ironed out.
Okay, and so you'll update, you're adding that to the grievance report on the patient protection reports, and you'll have a draft soon. Okay, thanks.
That's the plan. Any other RAC comment or public comment? Dr. Holliday? You're on mute. Sorry.
I apologize for my ignorance here. You guys have done a lot of hard work here. I'm impressed with the machinations of government and a lot of stakeholders involved. I'm impressed. More of a question. In reviewing or hearing the videotape of the first meeting, Jesse, I believe that you described a situation where insurers could use, I believe it's OHA, uniform prescription drug prior authorization process, and I wanted to learn more about that. One of the things I hear from my my staff at my office is that they're just looking everywhere for the information about how to pursue the prior auth. And I'm really happy to hear that it will be prominent on a prominent website, and that'll be fantastic. But also be nice to just if it was in one spot that all the insurance companies agreed to. And maybe there's some inducement where that could happen, but educate me more about what that would look like and what those thoughts are.
Yeah, thanks for the kind words. It helps when a bill has been worked a lot before passage. So I think a lot of the issues are already been ironed out. But in terms of the uniform prescription drug prior auth form, that is something that has existed for a while, and it's been a while since I looked into it. But we have a statute in the insurance code and some administrative rules that require health insurers to accept that form, and I believe the content of the form is also specified by rule. I can share that information. The bill here only very slightly touches on that. It used to be the case before this bill passed that if the uniform prior auth prescription drug form was used, then that was enough to satisfy certain other requirements around prior authorization in statute, and that has been eliminated because there's some requirements that I think that the proponents of the bill wanted to continue to apply, even in that instance. So that's a pretty technical change, but the form is still out there, and carriers should still be accepting it. I don't know if anybody else has any insights into that who might have actually worked with it, which I have not.
Yeah, Dr. Holliday, this is Courtney Dresser of the Oregon Medical Association. There was a long conversation about a bill to create a kind of a standard prior auth form. However, the bill also allows the insurers to seek additional information. So a lot of times the providers don't use that form anymore because the insurers just usually ask for their own form again. So it's sometimes just double work. So I think it's kind of obsolete now because of that language in the bill that allows the insurers to ask for additional information. So it's just easier to use their forms for right now.
All right. Any further thoughts, questions, comments, complaints? Hearing none, I think we can let you go pretty early here. So my feeling is that we have one outstanding issue, which is trying to nail down how to handle partial approvals or partial denials, either way you want to look at it, in the reporting. And I think that is ultimately just kind of inserting one more sentence into the draft rules. I don't think that we necessarily need to have a full-on meeting to talk about one sentence. So unless anyone disagrees, I think I'm going to cancel our next meeting. If you do disagree, please speak up now. Probably everybody's happy to have one less meeting. So what we will do in that case is we will work up a draft of that, which probably shouldn't take too long, and send it out and ask for written comment. And we'll give you a week or two to review it and get back to us. So for those who aren't familiar with our rulemaking process, even though this is it appears our last RAC meeting, there is still a bunch of different stages in the process, and there will still be some additional opportunities to weigh in. So Karen can speak to the specifics here, but we're going to have to file the draft rule with the statement of need and fiscal impact in the Secretary of State's bulletin, and then that will trigger the start of an additional public comment period, and we will have a public hearing to get additional feedback. Assuming all goes according to plan, we'll make any revisions based on that feedback, and then the final rule will be filed for a January 1 effective date. Karen, I don't know if you have any more details to share.
No, I don't know if, so this is mid-September. We'll just stay on the schedule that we've got. I think we were talking about doing the filing in October for a November hearing, but if there's a way we can push it up a month, that would be awesome for me. But we're right on track. It's all good.
Well, we will see what we can do. Seems like we're not too far away, so we'll see what's feasible. All right, any more thoughts, questions, comments for the good of the order here? If not, thank you very much, everyone. We'll be following up soon with revised draft, and we'll let you know how to provide feedback on that, and then we'll also let you know when the proposed rule is filed, in case you want to comment later on in the process.
Thank you,
Thanks,
Jesse.
everyone.
No baby yet?
Not yet, any minute.
Okay.
So yeah, future communications about this may be coming from somebody else, just so you know. But who knows about the timing? We will see.
Your baby should get a prior authorization for the delivery, I think. Best wishes.
Yeah, thankfully, that's not usually required.
Thanks, everyone.
Thank you.
Thanks, everyone. Have a great day.
Thank you.